Hey everyone, welcome back to ShockDoc Medical. I'm Dr. Raad, and today we're diving into a topic that's as intriguing as it is complex. Have you ever scratched your skin and thought, what's really going on here? Well, today we're going to decode the mystery behind scaly or hyperkeratotic red rashes. Whether you're a fellow doctor or just a curious soul, this episode is packed with details that can help you or your patients figure out what's behind these puzzling skin changes. In today's episode, we're taking a deep dive into a spectrum of skin presentations, from localized patches to widespread eruptions, and discussing everything from lichen simplex and varicose eczema to fungal infections, pilaris rosea, contact dermatitis, even Bowen disease, and beyond. We're talking about everything you need to know, right down to the texture of the rash and what happens when you scratch it with your fingernail. So grab your coffee, get comfy, and let's break it down together. First off, here's a cool clinical pearl. If you see a scaly rash, it's a hint that the pathology is involving the epidermis. A simple scratch with your fingernail that reveals scaling is a vital clue. This isn't just academic. It tells you where to start looking for the underlying issue. Let's talk about those cases where the rash is pretty localized. Here's a rundown of what to consider. Lichen simplex. Picture a localized, itchy patch where the skin has thickened from repeated scratching. That's your lichen simplex in action. Varicose, gravitational or venous stasis, eczema. This one is interesting. It's usually not terribly itchy. You might see a single patch developing over a varicosity. A quick tip, stand the patient up to check for dilated veins. Fungal infection. These are often asymmetrical and annular, ring-like. And here's a fun fact. If the patient has been using topical corticosteroids, you might actually lose that classic scaling. Not very itchy either, which can throw you off a bit. Herald patch of pilaris rosea, that initial solitary patch that signals the start of pilaris rosea. Irritant or allergic contact dermatitis, often triggered by an external substance, could be anything from a new detergent to a cosmetic product. Bowen disease, a bit sneaky, as it's typically not itchy at all. Red oozing nipple. This can be a presentation of atopic eczema, or in some cases, Paget disease. Asymmetric paraflexural exanthem of childhood. Think of a papular, scaly rash that's more obvious on one side of the body in children. Now, if you're dealing with a more widespread rash, the differential expands quite a bit. This is where you might consider scabies. Those pesky, itchy papules, nodules, and excoriations are classic scabies. Think about the intense itch and the distribution, often in web spaces of the fingers. Eczema. And here's where things get interesting, because eczema isn't just one thing. It's a whole family. Atopic eczema, typically very itchy and usually symmetrical. Seborrheic eczema presents as scaly, greasy-looking erythema with relatively little itch. Look for diffuse dandruff on the scalp, flaky eyebrows, central facial erythema, especially around the nasolabial folds, flexural erythema, and scaly papules on the chest and back. Sometimes you even see an annular pattern. Discoid, nummular, generally very itchy, with crusting and weeping. Astiototic, dry skin eczema. Itch can vary, often limited to the shins. Psoriasis. The itch level can vary a lot from patient to patient. Pilaris rosea or pilaris versicolor. These can show up as pigmented or hypopigmented lesions. Drug reaction. Medications can sometimes trigger these rashes. Secondary syphilis. Yep, this infection can manifest with a rash. Photodermatitis. Not super common, but something to keep in mind. Cutaneous T-cell lymphoma. Also uncommon, but it makes the list. Next up, let's focus on scaly annular erythematous lesions. When you see a ring-like lesion with scale following the edge or trailing the erythema, think about dermatophyte infection, tinea, or ringworm. Usually localized, but again, if the patient's been using topical corticosteroids, that hallmark scale might disappear. Pilaris rosea makes another appearance here. Seborrheic dermatitis typically affects the central trunk, flexures, face, and scalp. Psoriasis, or rarely CTCL, psoriasis is a big player in skin rashes. Subacute cutaneous lupus erythematosus, often drug-induced, with the patient being photosensitive, even though the face might be spared, which is pretty counterintuitive. Annular erythema, uncommon, and you might only see a few lesions. Now, let's move on to hyperkeratotic papules and plaques. This is when the rash is rough and thick, meaning the horny layer is really built up and doesn't get removed easily when you scratch. Ask yourself, is the rash follicular? Here's what to consider. Relatively localized conditions. Tumors. This includes things like viral warts, corns, especially at pressure sites, seborrheic warts, which can be numerous, actinic, solar keratosis on sun-exposed skin, keratoacanthoma, or even squamous cell carcinoma, SCC. Keratosis pilaris, those tiny, rough, parafollicular bumps you might see on the upper arms and thighs. Lichen simplex. As we mentioned earlier, itchy nodules or plaques. On the legs, they can sometimes mimic lichen planus. Hypertrophic lichen planus. This is the thickened, purplish, itchy variant often seen on the legs. It can resemble lichen simplex, and you might also see lichen planus in other areas like the buccal mucosa. Discoid lupus erythematosus, DLE. Look for scars, follicular plugging, and hair loss. Often you might only see 1 or 2 plaques. More widespread conditions. Chronic psoriasis. Occasionally you can see very hyperkeratotic lesions, particularly on the palms and soles. There's even a variant known as Reiter syndrome, which is pustular hyperkeratotic and usually very symmetrical. Another variant to keep in mind. Follicular hyperkeratosis. This is uncommon, but can be caused by inflammatory diseases targeting the hair follicle, including lichen planus, hereditary conditions, or even nutritional deficiencies like phrenoderma. And lastly, a word about erythroderma, which you'll find detailed in box 4.5. If a patient suddenly becomes red and scaly all over, we're talking about skin failure, a real dermatological emergency. In these cases, consider eczema, especially atopic or seborrheic, psoriasis, drug eruption, cutaneous T-cell lymphoma, CTCL. This is one of those red flags where time is of the essence. Now, while our discussion today is more about recognizing the clues in these skin conditions, rather than diving deep into treatments, let's throw in a couple of examples for context. For a dermatophyte infection, Tinea ringworm, you might consider topical terbinafine 1% cream, generally applied once daily for 1 to 2 weeks. In cases of mild atopic eczema, a low-potency corticosteroid like hydrocortisone 1% cream applied twice daily can be a good starting point. And for psoriasis, treatment varies widely, from topical agents like calcipotriene, usually applied twice daily, to systemic therapies for more severe cases. Remember, these are just examples, and any treatment plan should be tailored to the individual patient after a thorough clinical evaluation. You see, every single one of these details, from whether the rash is localized or widespread, to the type of scaling, to the subtle differences in itchiness, gives us vital clues in solving the diagnostic puzzle. It's like being a detective, piecing together a story that your patient's skin is telling you. And for those of you out there in clinical practice, these insights can literally change the way you approach a seemingly simple rash. I love this part of our journey because it's not just theory, it has real-world impact. Whether you're a patient trying to understand your own skin condition or a doctor trying to nail down a diagnosis, these patterns are your roadmap. And it's important to remember that while textbooks and guidelines are super helpful, each patient is unique. Always take a step back and consider the whole picture: environmental exposures, personal history, and even how the patient feels about their rash. So, what do you think? Have you come across any of these presentations in your practice, or even noticed them in your own life? I'd love to hear your stories and questions. Drop them in the comments or hit me up on social media. Building a community of curious minds who are passionate about medicine is what ShockDoc Medical is all about. All right, folks, to sum it all up, we've covered the intricate details of scaly or hyperkeratotic red rashes, from localized conditions like lichen simplex and fungal infections to widespread issues like various types of eczema and even the red flags of erythroderma. Each piece of information is a stepping stone to a more accurate diagnosis and better patient care. If you found this episode as fascinating as I did, please hit that like button, subscribe if you haven't already, and share this podcast with your colleagues and friends. And don't forget to leave your thoughts and questions in the comments. Let's keep this conversation going. Next week, we're going to uncover another groundbreaking discovery that might just change the way we look at medical science. Until then, keep questioning, stay curious, and remember, your skin might be trying to tell you something amazing. This is Dr. Raad signing off from ShockDoc Medical. Catch you next time.